Hello, and welcome to this overview of familial and hereditary pancreatic cancer surveillance programs. I'm Carrie Mansfield, Immunovia's Clinical Marketing Program Manager. The statistics of pancreatic cancer are grim. This year, it's estimated there will be 60,430 new cases of pancreatic cancer in the U.S., which is a 5% increase over last year's estimate, and 48,220 deaths. The 5-year survival rate of pancreatic cancer is just 10%, the lowest of any type of cancer. Why are these survival rates so low? Because the majority of patients are diagnosed with advanced disease. This graph on the right shows that if you can detect pancreatic cancer earlier when it's localized to the pancreas, then the 5-year survival rate is 39% compared to just 3% when it's detected in late stages. So how can we do that? One way is to have patients at greatest risk for developing pancreatic cancer enroll in a surveillance program. In this study, 354 individuals at high risk for familial or hereditary pancreatic ductal adenocarcinoma, or PDAC, were enrolled in a surveillance program where they had an MRI or endoscopic ultrasound of their pancreas each year. 24 patients, or 7%, had neoplastic progression. Of those, 93% had worrisome features detected before their diagnosis of PDAC or high-grade dysplasia. Importantly, 9 out of 10 of the PDACs detected during surveillance were stage 1 or 2 and were resectable, and 85% of those patients with PDAC survived for 3 years after diagnosis. Patients with PDAC that was detected as part of the surveillance program had significantly longer survival of 5.3 years compared to the high-risk individuals who were late for or stopped surveillance of just 1.4 years. So now that we know surveillance programs are effective at detecting PDAC earlier, let's talk some more about how these programs work. We'll start with some definitions. Familial pancreatic cancer is when a person has at least 2 first-degree relatives, so a sibling, parent, or child with pancreatic adenocarcinoma without a known genetic mutation. This accounts for 5 to 10% of all PDAC cases. Hereditary pancreatic cancer is when a person has an identified genetic syndrome or genetic mutation that predisposes a person to develop PDAC. This accounts for 3 to 5% of all PDAC cases. Another important distinction is screening versus surveillance of patients for pancreatic cancer. When we talk about screening for cancer, we're talking about testing asymptomatic people in the general population. An example of this is mammograms for breast cancer or colonoscopies for colon cancer. Screening happens in high incidence cancers. Surveillance for cancer is different. That means testing asymptomatic people who are at high risk for developing the disease. Because pancreatic cancer is a low incidence disease with about 12 cases per 100,000 individuals per year, screening the general population would result in a large number of false positive tests, even with a test with 100% sensitivity and 99% specificity. As a result, only patients at high risk for developing the disease should be monitored for pancreatic cancer. Here we list many of the known genetic mutations that predispose a person to pancreatic cancer along with their relative risk. An average person's lifetime risk of developing PDAC is 1.6%. As you can see, some genetic mutations have just a 2 to 3.5-fold increased risk of pancreatic cancer, like a BRCA mutation, whereas others, like the Peutz-Jeghers syndrome, results in a 132-fold increased risk for developing PDAC. In familial pancreatic cancer, a person's relative risk depends on the number of first-degree relatives they have who developed pancreatic cancer. For an individual with just 1 first-degree relative with PDAC, the relative risk is 4.5-fold. But with 3 first-degree relatives, the person's relative risk increases to 32-fold. The American Gastroenterological Association recently published a clinical practice update on pancreatic cancer surveillance in patients at high risk for pancreatic cancer, outlining which patients should be surveyed for pancreatic cancer, how they should be monitored, and how frequently. The AGA recommends patients with 2 or more first-degree relatives diagnosed with pancreatic cancer, as well as patients with certain high-risk genetic mutations, be monitored for pancreatic cancer. The AGA underscored again that individuals at average risk for pancreatic cancer should not be screened. Surveillance of high-risk individuals should start at age 50 or 10 years prior to the age their family member was when they were diagnosed with pancreatic cancer. For patients with hereditary pancreatitis, surveillance should start at age 40, and patients diagnosed with the Peutz-Jeghers syndrome should begin at age 35. The goal of surveillance is to identify resectable stage 1 PDAC and high-risk pancreatic lesions, such as IPMNs with high-grade dysplasia and pancreatic intraepithelial neoplasias. In terms of how surveillance should be conducted, patients should be monitored using MRI and EUS. If a patient has no concerning pancreas lesions, they can be seen every 12 months. If low-risk lesions are identified, as determined by a multidisciplinary team, then the patient should be screened every 6 to 12 months and should have a follow-up EUS. For patients with indeterminate lesions, an EUS should be performed every 3 to 6 months, and for high-risk lesions, an EUS should be performed every 3 months if it is not resected surgically. If a patient develops new onset diabetes while under surveillance, that patient should have additional diagnostic studies and a shortened surveillance interval. A recent meta-analysis reviewed prospective studies of asymptomatic adults at high risk for familial or hereditary pancreatic cancer enrolled in a surveillance program, with the goal of determining the yield of baseline imaging in surveillance programs. 24 studies with 2,112 patients were included in the analysis. Patients received EUS and/or MRI at baseline. They found that almost 1% of these high-risk individuals had high-grade dysplasia or stage 1A PDAC at baseline. The study concluded that you need to screen 111 patients to detect one high-grade dysplasia or stage 1A adenocarcinoma. The authors went on to state this is compatible with a number needed to screen for other accepted screening programs. For example, 98 patients with smoking history would need to undergo baseline low-dose CT scan to detect one lung cancer. A natural question arises after reviewing this information. What role could blood-based biomarkers play in the surveillance for pancreatic cancer? In the current paradigm of pancreatic cancer surveillance programs, MRIs and endoscopic ultrasounds are the standard of care for regular monitoring of patients, but both have significant drawbacks. MRIs are expensive and not all centers have the equipment, and endoscopic ultrasounds are invasive procedures for a high-risk individual to undergo every year or every other year. So if a blood test could accurately detect early-stage disease, it could be used to identify those high-risk individuals who would benefit most from imaging. In retrospective studies, the IMMray PanCan-d test has been able to detect early-stage PDAC with 94% accuracy versus healthy controls. The negative predictive value of the IMMray PanCan-d test was 0.993. If after listening to this presentation you feel you could benefit from a pancreatic cancer surveillance program, I've provided this map so you can see where surveillance programs are located throughout the United States. Immunovia has partnered with 23 of these high-risk programs for our PanFAM study, which evaluates the IMMray PanCan-d test in individuals at a high risk for hereditary or familial pancreatic cancer. That study has completed enrollment and interim results will be released later in 2021. In summary, I hope this presentation has highlighted the following points about surveillance programs. Screening the general population for pancreatic cancer is not feasible because it has such a low incidence, regardless of how good the test is. Individuals with certain genetic mutations and/or family history of pancreatic cancer have been identified at high risk for developing PDAC. Annual surveillance of those high-risk individuals is able to detect early-stage PDAC. Detecting early-stage PDAC as part of a surveillance program improves survival in patients with familial or hereditary pancreatic cancer. And lastly, an accurate blood test for the early detection of pancreatic cancer, such as the IMMray PanCan-d test, could save high-risk individuals from unnecessary invasive procedures. Thank you for your attention. I hope you found this presentation informative.